Welcome to the fourth talk of the neurology series. Again, we focus on just simple clinical approaches, and we forego excessive detail in these talks. So this one's about multiple sclerosis. Now, multiple sclerosis, or MS, has actually remained, like a lot of the disorders we talk about, unidentified for centuries. This is the fellow who probably, has the first definite documented case of MS. An Englishman by the name of Augustus d'Este, and this was in the early 1800s. He was an interesting fellow. He maintained a diary of all his symptoms, and from the diary, it's quite clear that he had MS. And that tells you right away that MS is a basically clinical diagnosis, right? They didn't have MRIs. They didn't have LPs and all these other tests that we use now. He was a rather optimistic fellow. He sort of cheerfully documented his symptoms, and he had a number of things, including diplopia, weakness, bowel and bladder problems, and tremor. Now, not long after, this Scottish pathologist, Robert Carswell, was the first person to actually draw MS. So the first was, Augustus there was the first person to actually write about it properly, and Carswell drew it. But he was mostly interested in the drawings rather than associating them with a specific disorder. So he didn't actually identify the scars, or plaques as we now call them, with any specific disorder. But he was very talented, and his atlas is still considered to be one of the most beautiful of all medical books. So there's one of his drawings. This figure clearly shows it's sort of the spinal cord and brain stem and part of the lower part of the brain. And you can see there's numerous plaques. I've circled some of them. And this is clearly showing inflammation-induced scarring in the brain, spinal cord. So, this is the initial sort of descriptions of MS. They didn't even know what to call it, or that it was a disorder. It certainly wasn't called MS. And it continued to remain nameless until the Napoleon of the neuroses came on the scene. I'm not sure if you know who that is, but it is the great French neurologist Charcot. He's also known as the father of neurology. He's not just known by that name. So this guy was the first person to put a name to it, and he called it, in French, sclerose en plaques, or plaque sclerosis, which is a very good name. He also proposed the first diagnostic criteria, which was actually not really specific for MS. But this became known as Charcot's Neurologic Triad. This is different from the more commonly used cholangitis triad that you probably know about. Okay, so it's a different triad. And the triad was nystagmus, scanning speech, and intention tremor. So basically, you could look at that and go, well, a lot of that's cerebellar, isn't it? So he was really looking at a certain subtype of MS, but there's a lot of MS that doesn't present like this. So it was not specific. But the triad, I was amazed by this. It remained used until the 1960s. And then we started to create more broad criteria. So we had the Schumacher criteria, and that continued to be refined into the McDonald criteria. And the McDonald criteria themselves have been refined every few years, and we now use, I believe the latest version is the 2017 McDonald criteria. So what is MS? MS is basically this sort of progression of three things. So you get perivenular, that's around the veins, inflammatory lesions, demyelination, and plaques. So if you look at the picture, it's the oligodendrocytes take the hit. So in MS, the oligodendrocytes, which form the myelin around the neurons in the brain, they take the hit from the immune system. So it's primarily T cells that attack them and their myelin sheaths. This produces an inflammatory response, of course. There are B cells and plasma cells and other inflammatory mediators involved, not just the T cells. But as this process continues, you start to get demyelination. And although the body does remyelinate after each and every attack and on an ongoing basis, the new myelin is progressively less durable. So the body can't make the same kind of myelin. I guess It's like cutting down old growth trees in a forest. New trees will grow back, but for them to become like the old trees, I guess it could take a very long time. Second growth is not quite the same, to use an analogy, I guess. So anyways, repeated attacks lead to less and less effective remyelination until eventually you get this scar-like plaque, like inflammation anywhere else in the body. Eventually the body just sort of starts producing a scar around the axons. And you get what looks, as you can see in this transection of the spinal cord, confluent demyelinating plaques. So that's essentially MS. Now, very importantly, you get progressive and irreversible neuron loss, but it's not till later. Okay, so therefore, you may have been told multiple sclerosis is an inflammatory disorder, but it's actually inflammatory and neurodegenerative. Okay, probably the inflammation predominates early on in most people. As you progress, the degeneration appears as neurons are dying later. So it's kind of a blend of the pathologies. How do you diagnose it? Okay, so history is always the key, right? Every single neurological disorder, even stroke, history is the key. So you want to know about the progression of symptoms in this person. And then you examine them. And if we're following someone with MS, we use this thing called the Expanded Disability Status Scale, or EDSS, so I'll briefly go over that. And we do use investigations heavily in MS to confirm the McDonald criteria, although they are mainly clinical. The investigations can be helpful. And we have to exclude mimics always, because MS itself is very complicated and can present many ways, so there's other disorders that it can look like, and that can look like it. Okay, so it appears subtly in its early stages. The person who gets MS already usually has some risk factors. Now, I'm not going to get too much into why these risk factors are correlated with MS. The bottom line is there's different theories, but some of the main risk factors are low vitamin D levels, previous smoking, childhood obesity, and a prior Epstein-Barr virus infection. That's not comprehensive, but that's some of the big ones. And it's very interesting, you know, what is it more genetic? Is it more environmental? Well, it's quite clear that adults who migrate to a place where MS is relatively highly prevalent, such as Europe, coming from a low-risk place near the tropics, so tropical zones have lower risk of MS, temperate zones higher, so there'll be more MS in the South Island of New Zealand than the North per person. Their children develop the high risk of MS. So if it was purely genetic, that wouldn't hold, would it? So there's got to be a greater contribution from the move itself to the new environment. Anyways, the person at risk often will always, of course, have an asymptomatic phase. Now, sometimes a person will get an MRI scan for something else, like a headache or something else. They're not looking for MS, but they find demyelinating plaques in the brain. And we see this quite frequently, well, reasonably frequently. We'll get referred for an abnormal scan even though the person doesn't have any symptoms suggestive of MS. We call this a radiologically isolated syndrome, or RIS. Okay, so the person has an MRI, there's demyelinating plaques in there, usually not many and they're small, but they don't have symptoms. So when patients do get their first symptoms at some point, having the RIS increases the chances of becoming MS, okay? Then actually, when you do the MRI on a person who's just developing symptoms, they almost always have other silent lesions that you can't correlate with the clinical presentation that have probably been there for some time and been silent lesions. And they also already have some brain volume loss, okay? So that means there's pre-existing inflammation and neurodegeneration before the symptoms occur. So the MS process starts likely years or even longer before the first symptoms. Make sense? So intermediate stages. So this is where you get your symptoms start to really come. So the first onset of symptoms, you don't usually call it MS. Sometimes you can, but usually you'll call that a clinically isolated syndrome, or CIS, as opposed to the radiologically isolated syndrome. That's RIS. So the CIS is the first neurological event related to the inflammatory demyelination of plaques, and it'll present as a spinal cord syndrome or optic neuritis or a brainstem syndrome of some, it could be any of these things. And it's sort of a one-off, and usually you can't make the diagnosis of MS, but you tell the person, well, you certainly have an increased risk, and we just, have to see how we go and wait and see if there's another attack. Now, if that progresses, which it usually does at some point, you get what is called relapsing remitting MS. Okay, so this is MS primarily characterized by inflammation, probably over degeneration. And you get these relapses that occur over hours to days. They build up, so they're not sudden and maximal like stroke or TIA. They build up over hours, days, and they reach a plateau that often lasts several weeks, and then they gradually recover. But despite the clinical recovery, there often is a little bit of permanent damage. Remember, the new myelin is not as durable, so it's not as good as the original. The latter stages, this is where a person starts to get some permanent disability. So with relapsing remitting, there's complete recovery, more or less, between each episode. But now we're starting to get incomplete recovery, and this usually occurs sort of after 10, 15, 20 years. The relapsing remitting MS becomes secondary progressive MS, and that means you have relapses occurring on a background of a subtle progressive decline. And although the relapses and inflammation attacks sort of diminish in intensity as we go, the baseline gets worse as well. So the progression, which is primarily due to the degenerative component, accelerates. Okay, so you can see how the MS changes. It sort of morphs from one pathology more into another. Now, that's the usual course. There are always people who are different. About 10% of people have primary progressive MS, and that is an interesting type of MS that involves a gradual progression, usually without really any much in the way of relapses like attacks, that starts from symptom onset and just gradually gets worse. And they will have certain phenotypes in how they present, so progressive spastic paraparesis, cerebellar, sensory ataxia, visual cognitive failure, things like that. So how similar is it to relapsing remitting MS? Not sure, but a lot of the pathological principles remain the same. Okay, so obviously you're going to examine them around step 3 when they're just presenting with early symptoms. Now, MS is really interesting because it can present with virtually anything, and so you've got to be comprehensive when you examine these guys. If the patient has been diagnosed with MS, and we'll talk about how to do that, we track it with this thing called the EDSS. We do an EDSS, say, once a year on a person, and you can see that it's quite comprehensive, and it looks at a number of different functions in detail. There's a number of things you look for within each of these green circles, and you give them a score. The EDSS is just a simple way to rate the severity of disability. It's kind of like the NIHSS for stroke. It just tells you about severity mainly. And so someone who's got a very low score, they can still sort of run and stuff, that might have an EDSS of 1, no disability, just some minimal signs. Someone who's moderately disabled, maybe they have trouble running, so they've got an EDSS of about 3. As you go up, it gets worse. So someone who needs a gait aid, they might have an EDSS of 5, and someone in a wheelchair would have a 7. So it's a very good score. It just gives you a snapshot of severity. How do you diagnose MS? That's the McDonald criteria. So, like I said, in 2017, the latest McDonald criteria were revised. The key thing to take away from this is that the diagnosis is primarily clinical. So you've got to have 2 things: dissemination and time. You need at least 2 clinical attacks to make this diagnosis, usually, and they have to be separated by at least 30 days. Okay, and the attacks have to be different. It's like different parts of the body indicative of 2 different lesions with objective clinical evidence. Nowhere in here do you need the MRI. Okay, so that does fulfill the McDonald criteria. So you can see it's clinical. Now, that is the top line there. So at least 2 clinical attacks with at least 2 lesions with objective clinical evidence. Now, There are other ways to make the diagnosis if you don't quite fulfill those criteria, and that's where the MRI and lumbar puncture become useful. For example, if you've only got one attack, you can still fulfill dissemination in time if you do a lumbar puncture and find these things called oligoclonal bands, which are basically aminoproteins that have indicated that there has been an immune system reaction in the central nervous system. And you can fulfill dissemination in space, but with an MRI scan showing 2 of 4 so-called typical regions being affected. And I'll show you what those 4 typical regions are on the next slide. Okay, so the criteria are designed to give you the ability to say, yes, this person fulfills the criteria for MS. It's still important to exclude the mimics, which we'll mention in a couple slides. Okay, so this doesn't automatically definitely mean it's MS, but they have to fulfill these criteria before we call it that. So we do use a lot of MRI. Just like in stroke, MRI is very useful in MS. And you usually like to get the brain and the spine. There are 4 typical regions that MS seems to have a predilection for, and they include the periventricular, juxtacortical, infratutorial spinal cord regions. So periventricular, around the veins, juxtacortical, near the cortex, the neocortex, around the edge of the brain. The infratentorial, so bottom part of the brain, like the cerebellum, for example, and the spinal cord regions. So what do those look like? So if you look at these 2, we have a sagittal side view on the left, and we have an axial, sort of a top-down view on the right. The red circle shows periventricular high-intensity signal. So these are MRIs. You talk about intensity. CT, you talk about density. So the red circle on the left, you see it's circling that tiny white area that the arrow is pointing to. And same on the axial on the right, you can see that there's an arrow pointing to this hyper-intense signal, this slightly whitish area. And those are the demyelinating plaques, some of them. There's a few in this brain. The yellow circle shows you the juxtacortical demyelination. So you can see in a different location up near the cortex, right near the folds of the sulci and gyri, that the arrow points to demyelination up there, and same with the axial on the right. Now, you can also have infratutorial and spinal cord regions affected. Those are the other 2 typical regions. So on the left there, you see the red circles around a couple of hyperintensities in the cerebellum. And on the right, you can see that the arrows point to these hyperintense regions in the spinal cord. So these are the 4 areas that MS likes to hit. And it's typically white matter because that's where there's a lot of axons and myelin. Now, if there are any active lesions, like the lesions that are responsible for a current relapse, for example, they may enhance with a contrast agent. That's why with MS, we often ask for contrast. We want to see if any of these lesions enhance. It's not the only condition that makes things enhance, but it is one of a few. The other investigation we often use is the lumbar puncture. And again, we're looking for oligoclonal bands. These are very useful biomarkers in MS. Up to 95% of people have them permanently. So even between relapses, they'll have them. And again, they are due to depositions of aminoprotein that are indicative of an immune reaction within the central nervous system. Okay, so those are your 2 main investigations for MS in terms of making the diagnosis. Now, in terms of excluding mimics, they're also useful, but there's a few other things you need to do as well. So we always are wary of mimics, and there are many mimics of MS. One of the most common is the other inflammatory demyelinating disorders. MS is not the only one. It has some cousins. Neuromyelitis optica, or NMO, is a cousin that's actually much more common in Asia and South America than in, say, New Zealand. And these people present with a severe optic neuritis and or transverse myelitis that's quite extensive over 3 vertebral segments. And they can get lesions in the medulla. They can even sometimes present with hiccups because of this. So if you look at this, this is a classic spinal cord of NMO. You can see how longitudinally extensive those demyelinating lesions in the spinal cord are. They're very long. And if a person presents with this and the brain looks really relatively okay, as in not much there in terms of demyelination, then NMO would be higher on your list than perhaps MS. There's another one called MOG antibody disease. It can present with a variety of things, of course, but optic neuritis and transverse myelitis are very common in that. It's usually not as severe as NMO. There's another one that usually goes for kids, and that's called acute disseminated encephalomyelitis, or ADEM for short. And that's due to a sudden, widespread attack of inflammation on the brain, mostly. And you get these smudged appearances on the MRI. So the demyelinating plaques look a little smudged. If you see in the circle, it looks like someone just sort of stamped some, I don't know, some smudged some paint on there or something. So they look more distinctive. Infections can also mimic MS. There's one called HTLV1. It classically gives you, it hits the spinal cord and you get it. So a myelopathy means a spinal cord problem. And that's how it presents. HIV and syphilis, we always look for them. I've diagnosed neurosyphilis only once, but hey, if I hadn't looked for it, I would have missed it. And so we do look for these things as neurologists because the treatment path would obviously vary quite a lot from that for MS. There's a lot of other mimics. So these are some of these four are pretty common, I guess. Cancer, particularly lymphoma, maybe metastases, they can mimic MS. They can even enhance on the MRI. So we've got to be very careful. We don't call that MS. Tractopathies, the classic one would be B12 deficiency, which gives you that subacute combined degeneration of the cord. Copper can do something similar. There's meningoencephalitis, can mimic MS. Neurosarcoidosis, another great mimic in itself, is another immune-mediated disorder that consists of, as you probably know, granulomatous inflammation. So those are some reasonably common mimics. We always look for them. Less common mimics that we still look for would include thyroid disease, CNS vasculitis, Beckett's, which I have not yet seen, and I guess I put stroke in there. Stroke is very common, but to mix up stroke with MS, it can happen, but really hope that nobody here does that because they are very different in how they present. Okay, so due to all these mimics, there are additional investigations other than the MRI and LP that you should order if you're thinking of MS. So blood tests, this is the list that I would use. You look for NMO antibody, anti-MOG antibody, B12 ACE, HTLV1, VDRL, HIV, VDRL is for neurosyphilis, TSH, and ANA. That's a good basic panel. It's probably overkill if you're GP. Of course, if GP, you're probably referring on to a neurologist to consider this diagnosis of MS. As a neurologist, that's what I do. Sometimes I'll push more into that if I'm really thinking of a particular mimic, but I think that's enough. And for the spinal fluid, in addition to the oligoclonal bands, you might want to look for cytology. That's for tumor cells, ACE, and tuberculosis. Okay, so here's a diagnostic approach for someone who you think might have MS. So you take a proper history and try to see if there's any prior stages of progression that indicate MS. So you assess all their risk factors, as I mentioned before, the vitamin D and the rest of them. You go over all the past and current phases that they may or may not have had. If you diagnose MS, then you're going to be doing EDSSs on a regular basis, so you can do an initial one. And then you will also be doing an initial MRI brain and spine and probably a lumbar puncture, and then you also follow them up with MRIs periodically as well. And of course, when you diagnose MS, you must exclude the mimics, so you do the appropriate tests, and the panel I showed you is basically good for doing that. Now, MS treatment is where it gets more interesting because this is an ever-changing thing. How we treat MS now is actually quite different to even 10 years ago. So this is very good because I'm not sure, in medical school you might be going mainly on older data, although of course I might be wrong about that. So there's several options. First, I'll talk to you about the non-drug therapies. These are rising. A lot of patients are interested in these, and they are of course diet, exercise, and smoking cessation, which seems obvious in something like atherosclerosis, but it's very important in MS too. Disease-modifying drugs, so we give drugs designed to modulate or suppress the immune system. Of course, we think this is a largely immune-mediated disorder, so that is the rationale behind them. Symptomatic drugs that don't really target the immune system, but they can improve the symptoms. And then I'll talk to you a little bit about stem cell transplantation, which a lot of people are getting excited about too. So there's an intense interest in non-drug therapies, particularly diet. Over half of all MS patients are trying a diet strategy for their MS. So that tells you right now that really this is probably an important thing to learn about. And there are numerous diets out there. So my screen just fuzzed out. Oh, there it is. So probably two of the most popular would be the Wahls diet and the Swank diet. Now, the Wahls diet and the Swank diet are quite different diets. I've got a figure here showing you the Wahls diet. It's basically a paleo version diet. So they're removing breads and grains, so gluten, processed foods, which is very good. Nobody would have eaten those in evolution. Eggs, dairy products, and of course, sugar, which is largely processed in the way we intake it now. So there's the pyramid. It's basically meat and veg. And then they do allow gluten-free grains and healthy fats and oils. But you can see the progression sort of relies on mainly on the fruit and veg and the meats. The Swank diet is a little different. It really lowers saturated fat, so it targets the saturated fat big time, and so it looks different from this one. Where do they meet? They both remove processed foods. So again, the removal of processed, if you don't know what diet advice to give a patient for any disorder, the most reliable and best evidence you can give them is just eat real food. What's real food? Stuff in the supermarket that doesn't have a label of the ingredients, right? Steak doesn't need a label, broccoli doesn't need a label. That's real food. Anything with a label, it's been processed. Probably, almost certainly. Exercise. Exercise improves outcome. So you absolutely should encourage people to exercise with MS. Vigorous exercise during a relapse may not be ideal. You increase your body temperature, that can worsen symptoms. So, use a bit of common sense when recommending this one. Smoking cessation, it's been shown that just quitting smoking improves the outcome. So I guess there's multiple potential reasons for that, but smoking would potentially worsen inflammation throughout the body and do a lot of other things that I don't think I need to go into right now. So let's look at a study. There was actually a recent trial that compared the Wahls and the Swank diet head to head. And it was just finished in 2021, I think, last year. So they took 87 patients with relapsing remitting MS, and they randomized them to the Wahls or the Swank. So Wahls, again, is paleo, Swank is low-sat fat for 24 weeks. And what happened? Remember, both diets remove processed food. So they're both better than the standard Western diet, I think. If processed food is the enemy, which it is, then they're both better, okay? Now, you have to be careful. I like the study, but Dr. Wahls herself was the lead investigator, okay? So you must always look at that. This is very common in drug studies. The lead investigator or a number of the investigators will be receiving financial compensation from the company, and again, there may be a conflict of interest here with Dr. Wahls and the diet she promotes. That being said, I do think the study was pretty good. Both the diet groups, they looked at the primary outcomes were sort of fatigue and quality of life and things like that. It's difficult to, for various reasons, to look at endpoints such as relapses and brain atrophy in MS. It can be done, but over a time period of 12 to 24 weeks, clinical outcomes are probably more suitable. So they both improved their fatigue scores, which is no surprise because, again, you're removing all the processed foods. And always remember, there could be a mild placebo effect here as well, because both groups knew what they were eating. You can't blind a person to their diet on a diet study, only the assessors. Both groups improved in quality of life scores in terms of physical quality of life. The Wahls did improve slightly more. Only the Wahls improved in mental quality of life. The Swank did not. And neither of them improved the 6-minute walking distance time. So that was at 12 weeks. And all those improvements were maintained or further improved by 24 weeks. So there seemed to be an ongoing improvement as the body adapted. And I must say, with our experience with diet trials, as you know, we do a lot here with ketogenic diets mainly. people continue to improve as time goes on. And after weeks, after months, and if they stay on it, we have some patients who have been on these things for years, they generally continue to improve. And that's the cool thing about diet strategies, is the hard work is at the beginning and you get better as you go. So long story short, both diets resulted in these were clinically not just significant improvements, they were clinically meaningful improvements. That's very important when you analyze a study, because you can get a significant statistical improvement if you have 1,000 people in the study and it's tiny and doesn't really make a difference. It's sort of like, well, it doesn't matter that much. But if you have a clinically meaningful improvement, as in it's kind of obvious to patients and people around them, that's what you want. So this improved fatigue and quality of life in a clinically meaningful manner, I think it's a useful thing to think about and talk to people with MS about the next time you may see one. Okay, let's talk about the drugs. So there are at least 15 drug options. There's probably a couple more since I prepared this slide. In relapsing remitting MS, we don't have a lot for primary progressive MS, so I'm going to focus on relapsing remitting MS. It's not devoid of drug therapy, but it's nowhere near as much. So the disease-modifying drugs have basically been shown to do three things. They definitely reduce relapses. That's their main benefit. They can clobber the relapses, so that's nice. A person doesn't develop those clinical attacks and have to go to hospital or whatever. They also probably diminish the accumulation of new brain MRI lesions, which makes sense, I guess. And they do seem to delay the progression of disability. Now, they don't generally improve the established symptoms. Of course, established symptoms are indicative of a bit of more degeneration, right, than inflammation. So that kind of makes sense. And the long-term benefits beyond 2 to 3 years are still really uncertain. A lot of these drugs are fairly new, and do they actually slow down the central process of MS in the longer term? We don't know at all. So bear that in mind. This is sort of a timeline of the introduction of the drugs, and I'm only going to mention a few of the drugs in particular. So you can see in the 90s, we used these two a lot, interferon beta and glutaramate acetate, injectables. And then around 2000, we developed Natalizumab, which is called Tysabri. That's a very powerful monoclonal antibody that we use quite a bit at this hospital. And then a few years after that, about 10 years ago now, fingolimod, teriflunomide, dimethylfumarate came on board. And now, just very recently, we've got ocrelizumab, another monoclonal antibody like natalizumab. So I'll just talk about those ones for a couple slides, because they're the ones that we rely on when we give the drug therapy. So that being said, we don't use these two much anymore. So glutaramate acetate or Copaxone, you give this 3 times a week. It reduces relapses by about 30% compared to placebo. And it's not bad in terms of adverse effects, injection site reactions. Interferons is the other old drug. This is has been called by various names depending on the exact formulation. So Avonex, Rebif, Betaferon. The administration is variable. The efficacy is about the same as glutaramate acetate. Okay, so it's got a few more side effects: flu-like illness, injection reactions, altered liver functions, lymphopenia, and there's a couple more. So this is what we use for pretty much the 1990s for people with this disorder, which is not that long ago, really. Now we've got some more drugs. These ones are orals. So we've got this one called teriflunomide or Aubagio. So the teriflunomide is the generic name. Every drug has a generic and brand name, as you no doubt know. Aubagio is the brand name, so best to stick to generics if you can. It's given once a day, and it's moderately efficacious, about 36% relapse reduction in the trials. Adverse effects: nausea, diarrhea, hair thinning, hypertension, liver functions, teratogen. So again, with any drug you give a patient, it's good to know the top sort of 3 or 4 side effects, and you should tell them. Dimethylfumarate or Tecfidera is another one that is given twice a day. It is moderately high in efficacy, so about a 50% relapse reduction. Pretty good. I like this one. And its main risks include gastrointestinal things such as, a variety of gastrointestinal upsets, flushing reaction, and lymphopenia. It has a tiny risk of this thing called PML. Now, this is a virus that at least half of all people have, and a normal immune system just keeps it at bay, and it just sort of sits in your body like many viruses do, right? There's just so many viruses inside our body. And the problem with MS is if you give these immunosuppressive drugs, this virus can reactivate, and if it does, it causes this condition called PML, which is very problematic. You basically get these lesions forming within the brain. It can be fatal. So it's good to know the risk. It's very, very low, but not zero with this particular drug. Fingolimod or Gilenya is another good one. This is given once a day. It's got quite high efficacy as well, about 50% reduction in the relapses. People who take this, just on the first dose, you've got to be monitored because you can get a really low heart rate. This is called first dose bradycardia. And you get these other things, macular edema, herpes zoster can be reactivated, liver functions, high blood pressure, slightly higher risk of basal cell carcinomas. And again, it's got a very small risk of PML. Now, Natalizumab is one that is also excellent. This is called Tysabri by the brand name. It's only given once a month. That's a big benefit right there. You come in for an infusion. Very powerful drug, about 70% relapse reduction. It's got a very good adverse effect profile too. The main thing is, so the virus for PML is called the JC virus, and if you've got a very, if you've got no JC virus detectable in you, in the blood, then you've got a very low risk of getting PML. But if the virus is positive, and like I said, probably at least half of all people have a positive virus in them already, then the risk is 1 to 3%. Now that's still pretty low, but considering how bad PML can be, and it can be lethal, you have to be very careful with this drug. And ocrelizumab or Ocrevus is a very new drug that we use. We give doses 2 weeks apart and then every 6 months, so that's great. People don't have to get the drug very much at all. Again, it's quite high in efficacy, 55% or greater relapse reduction. And so far, the adverse effect profile is not too bad. There's more being added to this because it's still quite new. So that's just a snapshot of the drugs available in terms of immunomodulation. Now you can use other symptomatic drugs. Again, MS affects so many things, as this picture shows. And so some of the things you can give, people can get neuropathic pain. Neurotriptyline, gabapentin, pregabalin, carbamazepine are all wonderful options for dealing with neuropathic pain. Bladder dysfunction is very common, so oxybutynin. Some people with more severe bladder dysfunction will actually need to self-catheterize. And that's not a drug, of course, but it's an option that doesn't affect the immune system. People can get mood disorders and sleep disorders, so you should try and treat those symptomatically. And there's a drug called famotidine that can have an improvement of mobility, so that can be useful in someone who's got impaired mobility in MS. Stem cell transplantation. Okay, so autologous stem cell transplantation is being used in people with MS now too. We don't use it here yet, but I know there is interest, and wouldn't be surprised if it appears in the next few years. So the basic theory here is you're trying to reset the immune system. So the idea is that the immune system is the problem. It's attacking parts of the brain, spinal cord, for whatever reason, and you want to reset it. So first you harvest stem cells from the bone marrow, from a person's bone marrow, and then you'll wipe out their so-called pathological immune system with very strong immunosuppressive drugs, okay? So you're purposely trying to destroy their immune system. And then you take the cells that you kept away from that process and you reinfuse them to rebuild the immunity. The idea is that the stem cells will produce now a healthy immune system in place of the pathological one. It does seem to have very high efficacy so far. Progression-free survival in about 80% of patients with no evidence of disease activity in just over 2/3 by 5 years. The problem is it's still relatively risky. And treatment-related mortality would be about 5 to 10% for high-risk patients. That's not trivial. Even in carefully selected patients, it's about 1%. So you must be very careful in selecting the right patient for this treatment. People can get also, in addition to that, opportunistic infections, secondary cancers, and autoimmune disorders, and reduced fertility, and so on. So, interesting option. I think some people would be suitable for this, but certainly not most. Not right now. Okay, so treating MS, you explain the diagnosis, including all options. You provide information to someone with it. And so it's always good to start any therapeutic approach with a talk about all the options. People need to know their options. You may want to monitor them first, not try any drug therapy, just do serial visits and imaging, maybe try a diet strategy if their MS is extremely mild and it's not disabling. Or they're just not keen on drugs. Not everyone wants a drug. But if they start to progress or they change their mind or they want this right from the start, you can definitely consider a disease-modifying drug. And of the options I gave you, you sort of want to tailor it to the person, depending on side effects mainly, but also how severe the MS is. If they've got established disease, you can try symptomatic drugs. And again, there's a few options that I showed you there. So to conclude this talk, MS is an inflammatory and neurodegenerative disorder. That's very important you're aware of that because it tells you a lot about how it progresses. And one or the other often predominates. The diagnosis relies on elucidating all of the various prior stages of the MS progression, the history, and then determining whether that person meets the latest McDonald criteria, which again are predominantly clinical. Now that we have quite a few treatments available for MS, and I'm sure that if I gave this talk 10 years from now, there would be a number of other ones there. But basically, think of the non-drug therapies. I think that the evidence is improving for those. So the diet strategy, removing processed foods, eat real food, exercise, stop smoking, all the good stuff. And the disease-modifying drugs, I think, are pretty good. They can improve quality of life. So these are the backbone. The drugs, they have been proven to reduce relapses, accumulation of new brain MRI lesions, and disability progression. I'm hopeful that in the future, I have to say that the non-drug therapies become the backbone, but we'll see about that. Okay, thanks a lot.